theory question is informed consent, sir.
Hmm.
So the generally speaking, consent comes from the principles of bioethics, which deals with non-malfeasance, beneficence, autonomy, and natural and disruptive justice. So it is a legal choice of what the patient wants, sir. So non-malfeasance being the primum non nocere, beneficence to do good and to care the patient. And the primary principle of consent is to give the patient his own dignity, freedom, and the choice to do what he wants to do with his own body. There should be no kind of any forcing him to do any stuffs. And there should be equality and equity. So every human being of an adult years and sound mind has the right to determine what shall be done with his own body, and the surgeon or the individual who performs an operation or a procedure without the consent of the patient is be equivalent to committing an assault for which he is liable in damages. So, informed consent is a process in which a healthcare provider educates a patient about the risks, benefits, and alternatives of a given procedure or intervention. So, the required elements for the documentation are the nature of the procedure, risks and benefits of the procedure, the reasonable alternatives, risks and benefits of the alternatives, and assessments of the patient's understanding. Exceptions of informed consent can be when the patient is incapacitated, in the sense when he is unable to take a decision on his own, and in times of life-threatening emergencies with inadequate time to obtain an informed consent, or if the voluntarily waived consent. So the purpose of informed consent is to give the patient sufficient information so that the patient has the opportunity to exercise a knowledgeable and informed decision about the use of the drug or device in the context of the treatment. So it deals with the rights of the patient, being the right to expect an adequate standard of care from his doctor, confidentiality about his history, to know what is wrong with him, and to know what he is going to be done. The main components are full disclosure, voluntariness, and competence. So full disclosure should primarily be done by the treating doctor or the treating physician. So doctor should explain the nature of the disease, treatment, and the procedure. As in terms of anesthesia, whether the patient is going to be undergone general anesthesia, regional or local, and what it means to be under this kind of anesthesia, and what the patient might experience or what he could feel or expect from the kind of anesthesia. And the proof of disclosure primarily being documents and witness. So written form of consent is the best way of getting a consent, because there is a valid documentation process. But the time consumption should not be taken as a variant. And next being the voluntariness, patient's decision should be voluntary, free from any coercion or unfair persuasions. And last being the competence. So patient should have the capacity to weigh, reason, and make reasonable decision about the risks and benefits. And patient should be cognitive, and it should not in no way affect these dimensions. So cognitive being the patient should have enough education and knowledge of the procedure being to be done, and it should not be influenced by any terms of cultural, social, or religious aspects. And the ability to consent, uh, again, there are two terms. In less than 12 years, the consent has to be taken definitely at least for the examination. And above 8 years, consent to suffer harm from an act not intended to cause death or grievous hurt will need an informed permission. So the doctor only should disclose, or should the right person to take an informed consent. So there are steps to that to legalize an informed consent. Both doctor and patient should make an assessment. In the sense, doctor should take a full history of the patient. His views, experience, and knowledge should be shared to the patient. Doctor identifies the investigation procedures to benefit the patient and explains the various options and their respective potential risks and burdens and the side effects. And doctor may recommend a particular option, but the decision always remains with the patient. And the doctor in no way can superimpose any one kind of technique to be pushed to the patient. Patient weighs up the potential benefits, risks, and burdens and makes a decision as how he has to be undergone the procedure. Patient may request a treatment that the doctor considers of no overall benefit at all. And there are a few IPC sections which can be taken into consideration from the doctor side, and it can't be punishable. So IPC 87, the act not intended and not known to be likely to come to cause death or grievous hurt, as done by the consent. IPC 88 deals with act not intended to cause death done by the consent in good faith of the patient's benefits. Whereas IPC 89 states that the act done in good faith for the benefit of a child or insane person by the doctor or by the consent of the guardian. Whereas IPC 92 states that act done in good faith for the benefit of a person without any consent, which is in emergencies. So in elective cases, case-specific information has to be definitely provided by the doctor, type-specific information for the procedure also should be explained in their own understanding language. Personalized one-to-one communication has to be done with the patient as well as the valid patient's attenders, and separate acceptance forms for disclosure of the comprehension and consent has to be taken. A surgical consent cannot be taken as an notion for anesthetist consent. And as in emergency cases, pre-prepared case or type-specific information can be shared. Pre-prepared disclosure sheets and video and other recordings can be taken into consideration. And process experts, incident and subject experts can be shared with the patient. So, and to finish up, against an civil or suit of alleged negligence, a carefully taken, competently performed, documented consent may still be the doctor's most efficient and valid defense in the court of law. So, informed consent should be taken in most priority before taking into any procedure into consideration. Thank you, sir.
Very good. Okay. Done well. But two things I would like to add to this answer that you have prepared. One is, what is the language in which you get the informed consent?
Sir, in the patient's own mother tongue, the language which the patient can best comprehend. If it is a patient is a migrant or an immigrant from other place, so best comprehended. So if not possible, to have a better translator to have a detailed explanation about the procedure, sir.
Yes, that did you mention that?
I just said a word in the best comprehended language. that I didn't mention translator. Sure, sir. Sure, sir.
And so that point has to be added. Second point we would like to add to that is
witness, sir.
Witness.
Witness is the patient and the attendant. Right? Yes, sir.
And witness signature is another important point. But more than that, how long an informed consent executed by a patient is valid? Supposing you get an informed consent today, and for some reason the surgery gets postponed, it's an elective procedure, gets postponed after 3 months later. Patient suddenly has not as money or some family problem, he postpones the surgery. How long that informed consent he has executed at one particular time is valid?
24 hours, sir?
I'm not sure. Elective surgery can go up to 1 month.
1 month, okay, sir.
But within that time, again, you have to review the patient whether any physiological or anatomical changes have taken place in the patient's body.
Yes, sir.
So that review has to be done, and then if there are no changes from what you saw him 1 month earlier, then you can accept the patient consent as a valid consent.
Sure, sir.
So these 2 points I think you should add, and I would just like to share